Hey everyone, welcome back to our channel. Today, we're discussing an important tool for emergency medicine, the Canadian CT head rule. This rule helps determine which patients with head trauma need a CT scan. Let's get started. Objective criteria. Here's the bottom line. The Canadian CT head rule is a rapid method of determining which patients need CT imaging upon presentation to the emergency department with head trauma. Many experts rely on clinical judgment to identify patients who need a head CT after trauma. The Canadian CT head rule provides objective criteria to identify patients likely to need neurological intervention or have clinically important brain injuries. The rule identifies high-risk patients with 100% sensitivity for emergent neurological intervention if any of the following are present: a Glasgow Coma Scale, GCS, score less than 15 at 2 hours post-injury, suspected open or depressed skull fracture, signs of basal skull fracture such as raccoon eyes or battle sign, more than one episode of emesis, or age 64 years or older. For moderate-risk patients, the rule identifies clinically important brain injuries with 95% sensitivity if any of the following are present: amnesia of 30 minutes or more prior to trauma, or trauma from a dangerous mechanism such as a fall greater than 3 feet, a motor vehicle accident with ejection, or a pedestrian versus vehicle incident. Let's look at the study design and population details. The study was a prospective cohort derivation study involving 3,121 patients across 10 Canadian emergency departments, conducted from 1996 to 1999. Inclusion criteria were blunt head trauma with witnessed loss of consciousness, disorientation, or definite amnesia, a GCS score of 13 or higher in the emergency department, and injury within 24 hours. Exclusion criteria included age under 16 years, minimal head injury, no clear trauma history, penetrating skull injury, acute focal neurological deficit, unstable vital signs, prior seizure, bleeding disorders, oral anticoagulation, reassessment of the same injury, and pregnancy. Baseline characteristics from the study population included a mean age of 39 years, with 69% being men. The mean time between injury and assessment was 3.1 hours. 73% of patients arrived by ambulance, and 13% were transferred from another hospital. Witnessed loss of consciousness was reported in 46% of cases, and amnesia in 87%. Initial GCS scores were 15 in 80% of patients, 14 in 17%, and 13 in 4%. Mechanisms of injury included falls, 31%, motor vehicle accidents, 26%, assaults, 11%, sports, 10%, bicycle accidents, 7%, pedestrian struck, 6%, head struck by object, 6%, motorcycle accidents, 4%, and other causes, 1%. Interventions included enrolling consecutive patients with head trauma, assessing all patients for 22 clinical features, and making CT imaging decisions by the treating physician. Follow-up at 14 days involved a telephone interview to assess for memory loss, concentration difficulty, seizures, or neurological deficits. High-risk rule performance showed 100% sensitivity and 68.7% specificity. Moderate risk rule performance showed 98.4% sensitivity and 49.6% specificity. Criticisms of the study include the exclusion of 363 patients lost to follow-up and 1,358 patients with minor head trauma. The 14-day follow-up interview had not been validated for precision in ruling out clinically relevant brain injury. Additionally, the rule allows for minor brain injuries to go unimaged, which may not align with practice in some countries. Thanks for watching. If you found this video helpful, don't forget to like, subscribe, and hit the bell icon for more updates. See you next time.